Hi, I'm Stephen Bruce. I run the Academy of Physical Medicine, and here's 45 minutes of free CPD for you. This is just an example of what we do. We run a free session every month, along with 70 plus hours of live learning with others CPD every year. If you'd like to see more, click the link in the info section below the video, and that'll take you through to our website. Enjoy. Good afternoon. Great to have you with us, as always. And we've got a particularly pertinent, a particularly relevant topic to discuss today. I'm joined by osteopath Liz Huzzy. Now, if you've been paying attention over the last 2 years, you'll know that she joined us at the start of what is known as the EdAChe project. I don't know how people come up with these acronyms, but it stands for Education and Assessment in the Competence with Headaches. She'll tell us about that in a minute, but EdAChe says it all, doesn't it? So she is the project leader in that. She's also a founder member of Osteopaths in Practice for Headache Management. She's been an osteopath for quite some time now. She's recently earned her master's in headache management. I probably got that wrong, at the university, I think, in Copenhagen. But anyway, it's Liz Huzzy. Liz, great to have you with us once again.
Hello, thank you for
having me. And look at you, you're a jobbing osteopath. You're here straight from clinic.
Straight from clinic.
And you are probably, certainly in manual medicine terms, one of this country's experts, leaders in knowledge about headaches, I'd have thought by now.
Yes, I think I could probably hold my hand up to that. Yeah. But yes,
well,
lots of
extra
studies. You don't need
to be falsely modest, do you? You started this EdAChe project 2 years ago.
Yes.
And I like to think that we helped to stimulate you to a fair old final number of participants in that. How many did you get in the end?
Enormously for phase one, and just for reminding, phase one was a study to see the existing headache knowledge amongst UK osteopaths, yes. And that was what we came on 2 years to ask your help to get people to participate. Yeah. And with your help, we managed to get 398 participants, which was it was an amazing number. It was almost 10% of the UK population. Osteopathic population. And
almost 5 times as many as you expected to
yes.
get as well, I think.
Yeah, and so it gave us a really robust piece of research and gave us really robust data. It was a very representative number, representative of people in all the regions, Scotland, Northern Ireland, Wales, yeah. Across all years qualified, all ages, all genders. So it was a really it was a cohort that really represented the UK osteopathic population.
So that was phase one 2 years ago.
Yeah.
Has that phase taken the whole of the 2 years?
No, phase one finished, that took the first 6 months. We collected the data, so we know where the gaps are, where the knowledge is good, where it's reasonable, and where there was uncertainty. So, and then for the last 18 months, we have taken that information and we have put together an e-learning course for to fill in the gaps that's clinically relevant and academically robust.
Right.
That it was the idea, and that's just we've finished now, and we're ready to roll that out.
So actually, we now have a fairly robust platform on which to build this. Probably as robust as anything in headache management in the UK, certainly. But this is worldwide, isn't it? You've got participants in Australia, I think, as well.
We have. I presented it to globally through an Australian physiotherapist who Watson people may know of, who's very high up in the head. And so I presented the project through his online symposium a couple of. At this point in time, we are still in the research basis, because so phase 3, which we're in now, is all about doing a before and after, see how effective the e-learning course is at increasing people's knowledge. So it's all aimed at that, but for the purpose of research, we had to define a cohort. And so the one that we obviously identify the most with and is the easiest for us to access is UK practicing osteopaths. So for this before and after study that we're writing now, and the deadline is in the next 24 hours, when, if people wish to participate, they'll get the whole 8-hour e-learning course free of charge. All we ask is they do a 20-minute clinically relevant questionnaire before and after, so that we can really determine how effective the course is.
Right. So they'll do 8 hours of training, all of which is, of course, valid CPD.
Yes.
Could you, I'm thinking off the wall here, could you conceivably sign up as an acupuncturist or a chiropractor just to do that learning, even if you can't take part in the research?
At the moment, no. But
Right.
but as soon as this is done, which will be the new year, then it's going to be
That
available.
quick?
Yeah.
Right. Okay.
In the new year, the data analysis and the writing up will take a little while, but we definitely expect the e-learning course to be available in 2022. And that would be to everybody, obviously.
And that e-learning course, I would imagine, based on what I know of what you've been doing and what you've told me, that's going to be completely new, isn't it? I mean, it's not the stuff that we learned in college, just rehashed, because
No.
basically they didn't know this stuff when we were in college.
No.
They didn't know where the evidence led us.
No, it's all about knowledge that you need in clinic. So it's about, the premise is a patient walks in with a headache. Do you know the worrisome signs? Are you sure they're safe? Are you confident in your diagnosis? And do you know when you can treat and when you should refer? And if you should refer, who should you refer to and why? So it's putting, taking you through that journey to make sure that you have all the knowledge you need to take all of those steps.
So just go back a step. I said you did a master's. You've just finished a master's. It is in headache management?
Headache disorders.
Headache
yeah.
disorders. I'm sorry.
Right,
But
okay.
you also presented that not just to a manual therapist audience, didn't you?
No, I mean, I was very lucky in that they accepted me onto the master's program. It's really meant for headache neurologists, and so I was the first practitioner within a non-medical framework to be accepted, and they were very open-minded and very welcoming. The advantage of it is that we just got the best science in the world to come and present and lecture me, so it's the most up-to-date information on what treatment, on the science and the up-to-date evidence, and what we know about headaches, what we know about migraines. And
How many on the course?
20.
Right, but presumably it runs every year. And
Every 2 years. Yes.
Can we assume now? Well, let me start with what I imagine would have been the basis of that course. That it's largely about it would have been largely about conventional management of headaches, which is quite probably drug related.
It is.
So now, will it be different? Will it be better?
No, it isn't. But, you know, if we're going to start, I definitely believe progress is all about collaboration and professional respect. And the one thing that they do have is access to the best science. Beyond that, obviously the treatment modalities that they look at are all medical. But it's still really important, because the patients that come in and see you will have been through those journeys. So if you have a knowledge of what medications, acute medications, prophylactic medications, if you have knowledge on Botox, at least you can then give informed opinion, an informed suggestion to your headache patients. So an example would be cluster headache. The best treatment for cluster headaches is fast flow oxygen or sumatriptan, and it's probably not. It doesn't mean to say that you can't treat them, whether you're an osteopath or a chiropractor or an acupuncturist, but you can have that conversation from an informed point of view. If this headache is known, that you'll come to see me, I can tell you it's known as a cluster headache because I recognise the diagnostic criteria, and these are your treatment options. These are the medical options, and then I'm happy to treat as well, but you can make a decision on where you want to go with it. So it's having the knowledge to be safe and give the patients all the information they need to treat with confidence, really.
Interesting that. Just taking cluster headaches, because you've mentioned it.
Yeah.
Instinctively, one would say, well, a patient wouldn't be in the least bit averse to having fast flow oxygen, because oxygen is not a drug. Of course, it is a drug like any other chemical, especially if delivered in abnormal quantities.
Yeah.
Does manual medicine fit into that? Do we have a significant role to play, or is it just palliative?
Oh, well, look, I'm passionate about what osteopaths have got to, and chiropractors and physios have got to contribute to the headache world.
We're going to have to come up with a word, aren't we? Because
we have,
you, I always say osteopaths and chiropractors.
I think we've got a massive...
Osteopractors.
Yes, a massive role to play. But at the moment we're on very weak footings because we don't have a strong evidence base. We don't have strong science behind us. So we may have patients that know what we can do. We may have lots of anecdotal stories, but it doesn't really change anything on the bigger picture of the headache world.
Yeah, we've got nothing we can go to the GP with and say, look, the evidence says that I am a good vet for this particular disorder. No,
I mean, a good example is the NICE guidelines in 2012 that came out for headache recommendations. Chiropractors and osteopaths and physiotherapists they're there a little bit, but not the stakeholders, they weren't really. But acupuncture got in there because the acupuncturist, the BMA and Mike Cummings, got some really good data, really good RCT trials, and NICE looked at it, and they're now NICE recommendations for migraine prevention is 9 to 12 acupuncture sessions. So if we aspire to do that, that's where I'm at the moment. If we can, I'm sure we can do that now. But in order to do that, we have to have people within our professions that can know the difference between the diagnostic criteria of a tension-type headache, migraine with or a cluster headache, hypnic headache, post-traumatic headache, medication overuse headache.
And let's not forget aura without pain.
Aura without pain. And of course, cervicogenic headache.
So I only say that because I admitted to Liz that I get that from time to time, and I want treatment. So that's why you're here, really. So I guess everybody's going to ask, well, what does the evidence, as far as you're aware, currently say about which manual therapies are available for or are effective for which treatments? For which
they're very low down. There's not a huge... The evidence is there, but it's still relatively small compared to the big hitters. And so it always comes as an afterthought. It's always, and physical therapies could help with
How much did
this.
the BMA have? Or so the British Medical Acupuncture Society, BMAS, how much did they have? Because, I wouldn't imagine they're any wealthier than osteopathic organisations in terms of research, but they had enough evidence to sneak into the NICE guidelines.
Yeah, but the advantage is that Mike Cummings was a medical doctor, and he understands the language that you need to, and the science, and he does acupuncture at I think it's the Homeopathic Hospital in London, so big cohort of people to coming through that can get this on National Health Service. So he's got the participants, and he's presented acupuncture in a way that NICE guidelines can understand. I think that's my take on it. My personal take on it. And I think there is a big argument about whether the medical framework has got it completely right, and they don't understand. They're only looking at it from one angle. But the fact is that that's majority rules at the moment. So I think collaborating. It's definitely the way forward. Yeah,
definitely. I'd never really thought about how unlevel the playing field is until you mentioned what you just said. If you are a doctor, you've done a lot of medical training, but when you become skilled in anything else, you are entitled to use that as therapy, which means you've got an unlimited number of patients at your disposal because of the NHS system. But of course, unless you're a doctor who's trained in osteopathy, and there are very few who would want to spend another 3 or 4 years qualifying in a different medical discipline, that's never going to be one of those options that they use, which cuts down the number of people that you can put into the research pot.
Yes, I mean, there's a good research is a whole other conversation to be had, but definitely the more knowledge we have, the better place we are to collaborate with patients, with the medics, or with research. So if you're the more solid knowledge you have, the safer and the more effective you're going to be for your patients. And that's, after all, what we all do it for. Yeah. But also, you're going to be able to collaborate, and you're going to be able to speak with the GP in a language they understand. And they're going to know that you're safe and you understand the limits of your scope of practice. And you're not going to and ignore going back to the cluster headache, you're aware that fast flow oxygen is a good option, and you're not stopping patients find that.
How easy is that to administer? I mean, I've administered high volume oxygen to people in first aid situations before. Is it no different to that?
I've never administered it.
Right.
It's not something I offer. It's fast flow, but I know about it.
Is it readily available for the NHS?
It is. There's a bit of complication because oxygen, it's explosive, inflammable, and all of that sort of thing. But there is a, EdAChe, which is the patient for cluster headache, the advocacy. What's the word I'm looking for? They're patient advocates for cluster headaches. It's called EdAChe, and you can patients and get them to contact them or contact their GP. But just giving the patient the right information based from accurate knowledge.
Yeah.
It's so important. We're in such a perfect position. We have time to ask these questions. We can manage. Even if your patients don't come to you with headaches, we know that patients with migraines are more likely to have pain by far. So they may come in with you to see you for their low back pain. When you're taking their case history, they may not come to you for their headaches, but you're in a great position with good knowledge to really help them manage and find the right treatments, whether that's treatment or lifestyle advice, whatever it makes a difference. You can be a really important part of that headache patient's journey.
You kind of answered this. Pip sent in a question a little while ago asking whether the programme included migraines as well as general headaches, which clearly it does because you've talked about those already. I often wonder whether migraines ought to be a completely separate subject from headaches because the mechanisms seem to be totally different. Am I right in that?
Well, it is. I mean, they divide the way the framework for the knowledge that's included in the course is based on internationally accepted framework for the headaches you should be able to recognise within a primary care setting. Mm-hmm. So obviously those are the worrisome headaches. So you need to, and get to see a huge amount of those, because people would tend to go to A&E or their GP. But if they're not feeling well, or if it comes on too quickly, a thunderclap headache. But there are other ones that do slip through the net, and so obviously to be able to recognise potential red flags and what to do with them. How quickly should you refer them to the GP, or what investigations should they have? That's all in the course.
Am I going to be surprised by those red flags? What are they?
Well, these are what we call potential red flags. So this means not every single person with them is a worrisome headaches, but it's something that you should just think about. So it would be new onset over the age of 50. It would be any changing headache, obviously sudden headache, the thunderclap headache, anything where there's general unwellness. If there's a history of HIV or cancer. So there's a few that you can just tick off, and you need to know those, all right, because potential.
I always thought it's quite strange, actually, again, going back to first aid. When we teach first aid, we talk about stroke, and everybody thinks about the FAST test, but one of the major potential warning signs of a stroke is a sudden onset of headache, sudden severe headache. But it's not mentioned in any of the campaigns that have gone out on the various media from the NHS.
Yes, well, I mean, fortunately, I think, and that's one thing that they press upon, actually, in most cases, head pain is the least reliable of the red flags. Yeah. So that's not one of them. But anyway, so the framework goes through this course. So we start off the course with safety. So then you get to a point of, okay, I know that I'm safe to treat the green flags. I know that I'm okay. And then the next bit is recognising the kind of headache is. And headaches are divided into two. Primary headache disorders, when the headache itself is seen as the condition itself. And that is tension type headaches, migraines with aura, and tax. These are the cephalgias. Cluster headache is the best known one. There's a few others, Suna and Sunkt. And then there are other secondary headaches. So that's when the headache is secondary to another condition. And one always thinks of those of tumours and, worrisome ones, but there's a lot in there that aren't worrisome. Cervicogenic headaches would be considered a secondary headache because it's secondary to spondylosis or disc issues or something like that. Post-traumatic headache, which we see in post-traumatic headache, which we'll see in headache because it's come after a trauma. Medication overuse headache, that's a secondary headache that we would see I see a lot in practice. And if you know how to recognize medication overuse headache, and how to deal with it, and when it's complex or when it's simple, and what to do with it, what the benchmarks are to make it medication overuse headaches, then you can be really helpful to your patients. Because when you come off that 50% immediate reduction in frequency and intensity of headaches if it's medication overuse, just by knowing what to do about it. So that's what's in the course, those basics.
You make it sound as though it's a nice clear-cut thing. Someone comes in, you'll immediately be able to compartmentalise them into migraine, medication-induced headaches, cervicogenic. I bet it's not that simple.
It's not that simple. I mean, and there's lots of blurry, there's lots of grey areas. Most headache patients will come in and they'll have two types of headaches. They'll have an ordinary background headache that they can kind of work through, and then they'll have the headaches that make them floor them and make them go to bed, to their beds. So clinically, it's not black and white. But I think what really helps is having black and white structure to your case history, knowing what questions to ask, knowing what's important, being able to, and I know as osteopaths we generally, and I'm sure it's the same with chiropractors and physios, we don't like to put a medical label on it, but what that does do is give us a really strong structure to then know what to do about it, and I think that helps. I know it definitely in my practice, it helps me manage my headaches with some clear boundaries. Obviously we know things merge, clinically things merge, but it does help.
One of the key things, of course, in good outcomes for patients as well as safety is making your decision on what it is you're treating based on good evidence, isn't it? And a knowledge of what the signs and symptoms and everything else could
Absolutely.
be. And I suspect my tutors would say it's because I didn't pay attention, but when I came out of college, I don't think I really considered the different causes of headache. It was very often a case of, manipulating the upper cervicals often helps with a headache, let's try that, which isn't a good basis to justify yourself in the subsequent court of inquiry.
No.
I'd have thought.
And the fact is that C2-3, upper cervical afferents, are hugely important in headache pathways, whether it's via the trigeminal cervical complex and the part that plays in migraines, whether it's a cervicogenic issue, whether it's hugely important. So what this does is not change your treatment. I haven't found it's changed my treatment. I'm still fundamentally an osteopath, but what it's done is giving me the knowledge to use my treatment with confidence, knowing that I'm safe and I'm clinically relevant, and I have given the patient in front of me all they need to make an informed decision.
Actually, we were talking about this in a case-based discussion, something similar a few days ago, and that very often you cannot come to a firm diagnosis, and so you think, I'll do what I've done in the past, because quite often that's helped, and then we'll monitor and see what happens, obviously working within the bounds of safety. And as you say, far better, particularly with something where there are potentially some big red flags, far better to work on the basis of good education, and even if you get it wrong, the fact that you followed the right process and you've made your diagnosis on the basis of those key points, that's really, really important.
I'm very reassuring to you as a clinician, very reassuring to the patient, and this clinical reasoning of why
you might know the figures behind this. I'm springing this on you because it's just occurred to me, but I would venture to suggest that an awful lot of patients who have headaches don't go for any form of medical attention. They'll go to the shop and buy some paracetamol or some aspirin, and they'll just take their drug and hope that it goes away. Have you any idea how many of those might be helped by some sort of intervention, not necessarily osteopathy chiropractic?
Well, I think a few statistics. I think 95% of people will have a headache at some time in their life. Around 14%, and that's pretty globally, whether developed or undeveloped, but 14% of women will have migraines, 11% of men will be migraine sufferers.
And do we know that those are actual figures or are those just reported migraines? I'm guessing it must be the latter.
They have, but there's been a huge studies. Steiner's done some huge epidemiological studies over the last 10 years across the world, global burden of disease, of headaches, and that's why. So they've got real data from, I say, from Nepal to Argentina to Africa to Europe. They've got a really good map of where people's, and it's pretty, I think South America is quite high and Japan is a little bit lower, but generally it's pretty much the same across the board. So it's Steiner's work, epidemiological study, that's really put headaches up on the political and health agenda, public health agenda, because it's now number 3 on the World Health Organization list. So we've got low back pain, anxiety and depression, and number 3, headaches. And what are the 3 things that probably come through our front door? So if we need to know about it.
Yeah. Turning back to migraines, Christina has said that she can see off, inverted commas, a migraine as it first shows itself by giving C2-3 a flick, her terminology. It's also associated with the stomach meridian. Now, I don't know which profession Christina is, but clearly she's poked some needles into something, I would have thought, from that. Is that what you would have thought? You can see off a migraine from C2-3 adjustment?
I don't know. I've never known any robust data to support that. But I understand, as I said before, we know that the cervical afferents, C1 to 3, feed into the trigeminal cervical nucleus, and we know that it's complex, and we know that's the engine room of migraines. But alternatively, I think it probably get as many people saying, particularly patients, that say if you have vigorous treatment to C2-3, it will trigger a migraine.
Really?
So
what is it that defines a migraine as opposed to any other sort of headache?
A migraine, according to is a genetically predisposed neurological, completely reversible neurological event. So it means you've got to have the genetics.
How would they gauge that? Is
there a
marker?
But normally you'll have either a parent or a grandparent. Right. Who will have, and that's one of the questions you need to ask, because that will help you with your diagnosis.
But they haven't identified a specific genetic marker itself for this.
No, I think there is some in genetics, but I think there's a lot of work going on to that, but that's not something that I know anything about. But it's completely reversible neurological event. So when you're talking about your aura without the head pain, your migraine, that aura is a neurological event. It's a cortical spreading wave of negative and positive ions that are sweeping through your visual cortex, and that will give you those scotomas, and it'll come and it will go, and it'll be reversible within 20 minutes, generally around that sort of time. It will leave you washed out. We now know with functional MRIs, and that's where the science from University of Copenhagen it was so great, because it came from Harvard and it came from King's, and you've got functional MRIs now watching this, so that what we know about migraines is so much more. And it is a neurovascular event. It's not a musculoskeletal event.
Yeah.
And I think if you know that, I do believe that the neurology, modulating neurology with techniques can feed into that. But I think we still harbour back to the old musculoskeletal causes for migraine. We're never going to be listened to, because the science is just not backing that up. But it's
so often true about everything we do in our profession, isn't it? Because long ago we had these theories about what it was we were treating, what we were doing, and I don't want to get into any specific areas. And actually, we don't really have any proof that our theories were true. We just know that the treatment was effective. And if the treatment isn't addressing those neurological components, but something else which is feeding into them, then that's good. But we've still got to prove that.
Or not prove it, I think we've just got to well, I think we've got to, evolve and learn and try and be curious and say, okay, I mean, that's the whole reason I started this project was because I'd had 25 years in practice and I knew that some patients responded very well to my headache patients, really well, and I knew some didn't, and I didn't know why. I couldn't tell the difference. So how can I,
Can you now?
How can I think I probably can.
Yeah, good.
Well, better than I could, for sure.
Well, it'll never be 100%, I imagine.
But I think I've got the knowledge to definitely be that have filled the gaps.
Yeah.
And through that, I'm more confident, definitely clinically more confident to treat and do what we all do really well, which is treat effectively.
Yes. Christina has admitted to being a chiropractor and doesn't do her own acupuncture, but that was the origin of her intervention a moment ago. You produced a video, haven't you, about the next stage of the EdAChe project? Yes.
So this video, hopefully you're going to see it now, yeah. and it starts off. You'll see this at the beginning of the course as well. So what it is an everyday patient that you would see in your clinic with the questions. I'd like you just to watch it and then work out what it is. Is there any signs in there that you would be worried about? Would you refer this patient? What if you would refer them? Why would you refer them? What would you want from the referral? Or would you be confident to go ahead and treat them? Or do you think you should send them somewhere else?
Brilliant. Let's have a look at the video.
Mrs. S is 57 years old. She asks if you can help her with her headaches. The very strong throbbing pain is always around either eye. She has had 8 attacks lasting 3 days over the last 30 days. She visited A&E and her GP, but nothing has helped her headaches, so now is looking for answers on her own. She has had migraines since she was 12, but they always went away with tablets she got from her chemist. Once in her 20s, they were so bad her face and arm went numb down one side. The brain scan was normal. They said it was stress. For years she has taken painkillers for the neck, lower back and knee pain. Nothing works now. Could it be something in her neck causing the pain, she asks? This course will give you the confidence to know what questions to ask, to recognize what kind of headache it is, to refer appropriately, or help her find the right treatment.
Do you know, I like that video because it's the second time I've seen it, but it throws up all sorts of questions in your mind, doesn't it? 57-year-old woman, you're, oh gosh, because there's bound to be some menopausal components in that, and then there's some drugs thrown in a bit later on, and visual components. And what would you do with that lady?
Well, I can't say, because otherwise our before and after study will be completely put
Okay, so what do you want to get from that video, and so you need more participants in the next phase of this
yes,
project,
what's really helpful for us at this stage, so that the whole project we've tried to be as robust as possible, which is why we bothered to do phase 1. So we found the existing knowledge and where it was good, and it was good in many places, and where it was reasonable, where there were gaps and where there was a lot of uncertainty. Then now we've put this e-learning course together based on this framework of knowledge that we know people should have in a primary care setting. And now we're at the point, we could just roll it out. But because we want to make sure that it's really robust, we've done this in collaboration with the University College of Osteopathy and with EdAChe. So we want to make sure that, just giving people knowledge doesn't mean to say they're going to take it on board to make it clinically relevant. So we want the people to take a 20-minute questionnaire at the beginning, and they're all clinically relevant cases. And there'll be a few questions on what you think's going on, and then do the 8-hour course. They could do the course and then answer some similar questions at the end to see if that journey, the course is taking you on a journey and has actually given you the knowledge and the tools to be effective in the clinic room. And once we can put that data together, then we're really confident to roll this out. Now, when we roll it out, we'll probably break it up into modules of 2 hours e-learning and face-to-face courses, but that's another conversation we can have. But for now, we need people. The deadline is actually tonight, midnight tonight for people. It's free. Unfortunately, and I'm really sorry, all the chiropractors and physios, but at the moment, we had to choose a cohort because it is research. So we have UK practicing registered osteopaths, you can get it the 8 hours free if you just send an email to, I think you've got it coming up, it's edache3.opa.org. And we will do the rest. We'll send you all the stuff that you need to do. I've managed to extend the deadline because I knew I was coming on here today. So for you guys and for your viewers, I've extended it till midday tomorrow. Yeah. So yes, it's 8 hours a week. There are 20 modules. Each module is designed to be around 30 minutes. So it fits perfectly into an appointment, an empty appointment slot in your day. So
good idea.
That's an hour a week, really, for 8 weeks, this side of Christmas. And it will, once we get this, again, it's all being presented to the medical profession, to my people to the neurologists back in Copenhagen. So it's a really good opportunity to get the knowledge and really show the world that we're taking it seriously. Yep. We're taking our role seriously. We're being accountable and we're gaining the knowledge we need.
And on the plus side for the chiropractors, it means they don't have to do this, but they can still come on the course, the face-to-face course, once this 3 or 4 month segment has been completed.
Yes, once we've got this and we've got the data, and depending on the data, there's going to be feedback too. I think there's free text feedback, and we might have to make a few tweaks to if it's response to make so we can make it better. But the finished product, we're trying to make as high quality as possible. Yeah. There's nothing in the course that cannot be backed by academically robust papers. So it's up to date and it's robust. We will keep it up to date on an annual basis, a team, 5 of us at OPHM. So we're constantly reading the research that's coming out and we will update it all the time. But going forwards, to make it user, because I think we're all a bit screened out at the moment with...
Don't say that.
Well, I think, going forwards, we're thinking... Okay, we'll probably put it into modules, say one module on safety and case history taking. We'll send you the e-learning modules and then we'll do face-to-face where we can have interactive role-playing, make it far more, so you can get the knowledge and put it into a real-life situation and we can tell you our experiences and how best we do it in our own clinics.
And on that note, you are probably, if not the final, one of the very last guests who will ever appear in this studio, because we're moving our studio and we're having a much bigger studio. But I'm going to lock you in this one until you agree to run one of your face-to-face courses in the new studio, which will be... it's much better.
Well, I will have to check with the rest of the team, but I'm sure it will be...
You'll have to do it by phone because you're not getting out of here until you've agreed. So.
I'm sure, we're making plans already for going forwards, but the course itself will definitely be rolling out.
You're going to run it all around the country, aren't you? You hope. So.
Yeah, that's the idea. The idea is that we'll have teams of 2, but and we will take it the face-to-face days to you, so we can do some up in Scotland or Wales, but obviously the e-learning modules you can do beforehand, so it makes it effective.
I got a technical question for you.
Okay.
Sharon says, could you explain the hormonal causes or reasons for headaches, particularly in menopause, and how to manage it?
Oh, massive question.
In the space of 2 minutes.
Oh, massive question. Massive question. Well, there's 2 types. There's pure migraine, pure hormonal menstrual migraines, and they are the category where there's no other factor. It is pure hormonal migraines, and so they're the ones.
So it always happen during a period, or
always happens, in your cycle. Usually starts as soon as you're 11, and changes. It goes when you're pregnant, and changes again when your hormone levels change. And there's pure menstrual migraine, but they are such a small part. The most are what they call menstrually related migraines, where it is a factor, but it's not the only factor. Mm-hmm. So when it comes to menopause, the same can be applied. Now, there's so much now about menopause at the moment, and the same things apply to the migraines, lifestyle stuff. Try not to have a low GI diet, so that you don't have sugar peaks and troughs. Try and get some exercise. We know aerobic exercise, 70% max heart rate, not 100%. So if you go hard workouts will probably make your migraines worse, but around 70%, so that's a brisk walk. they definitely make it better. There are some supplements that are really good for migraines, and coenzyme 10 and riboflavin, magnesium, and that's regardless of menopause. But there's the coenzyme 10 and magnesium can be they can be helpful around there.
Is this sort of information available on the OPHM website?
It is available in the course.
In the course, right? Good. So, well, poor old
some of
chiropractors and
it, not all of
physiotherapists,
it,
but
not all of it. Some of
yeah,
it.
But we do need to encourage osteopaths to sign up for this course and reassure the chiropractors that it'll be
It
available.
will, definitely will
in a very
be.
few months'
We're
time.
not keeping anybody out. It's just, as I say, we had to choose a cohort, and that's the one we could access.
The part of that question was, you said that it's hormonally related. What actually are the hormones doing to provoke that pain? Do we know?
I won't profess to be an expert on menopause at this point. So there's various papers now looking at migraines as a metabolic changes. There's all the neurophysiology that creates sleeplessness. We know sleep and headaches go hand in hand. So the sleeplessness that you get with menopause can also feed into the migraine pattern. So it's a big question, and when your patients come in and they are menopausal, their options for the menopause, you kind of got to separate into two things. Okay, should we just deal with this as a menopause, and your migraines are an expression of the menopause that's going on, so let's stick with the menopause. And those options are all down to patient preferences. Some patients just are very happy, and it's really important to remind ourselves it's not our preferences, it's the patient's preference. And some patients are very fine taking medication, and HRT or amitriptyline for tension-time headaches, or propranolol for migraine. They're fine with it, it doesn't bother them. That's their choice. They are effective, but there are equally patients that really don't want to take medication. So to be able to offer them accurate information so they can make an informed choice about how they want to deal with it is really our job, I think.
We've probably got time for one more question on this. Actually, I'll feed something into you now, because okay. Helena has, Helena Bridge.
Yes.
I don't usually read out people's surnames, but we all know Helena. She says you're a superb ambassador for this project, and says thank you, which I'm sure everybody else would echo as well.
Thank you, Helena.
And Helena's been part of the project as well, I think.
Yes, there's a team of 5 of us. We, Vinod, Helena, myself, Mark McWilliams and Karina Brukel. We've all done, Helena and Vinod did their headache and pain masters up at the University of Edinburgh. I did mine in Copenhagen. Mark did his in Cardiff. Karina's studying at the moment, but she's got a daughter that was an osteopath, trained to be a BSO and had cluster headaches, so she comes from from that point of very, very knowledgeable. And so the 4 of us together, or 5 of us together, have brought lots of things to the table. But we have all for one reason, is that we were all experienced osteopaths, all with the same questions. Why does these patients respond well? Why do these patients why don't they respond as well or at all? Should I be sending them somewhere else? Or am I missing something that I should be worried about? They're all the same questions.
Okay.
And I just finish it with just like this project could not have happened without the collaboration of ENCORE and UCO.
No, of course.
No, because they've been huge support for us, and the OF have funded it. So, Osteopathic Foundation,
yeah. Which is wonderful. It's great that
massive
that's
collaboration.
I had one question still in hand. There's one quick one from Yekaterina who asks which magnesium is good. Is it magnesium citrate?
That's the one that seems to be come up tops.
Right. And my question was, I ought to know, but I can't remember what we're allowed to say about osteopathic or chiropractic treatment of headaches in our advertising. It's probably something along the lines of some some types of headache will respond to treatment. Do you think we'll be able to convince the ASA that we can be more specific in our marketing from now on about, I say marketing, I mean informing patients through our websites and other means about what we can treat?
It's the stuff at the moment is very vague. And the fact is, it's very vague because there's no definitive science. So we can persuade the AS to change anything if we get some robust research. We don't have to persuade them. It's our jobs,
but will we have that sort of robustness as a result of this project, do you think?
Well, I think this was the beginning. We get the knowledge out there, so people were doing best for the patients. And then for the people, the osteopaths, chiropractors and the physios out there that want to collaborate, we're all probably multi-centred. So everybody's got to, if we're going to do any research, it's going to have to be that sort of format. But everybody needs to be speaking the same language. So if we're all going to do a multi-centred trial on tension-type headaches, then everybody in those centres need to know what the diagnostic criteria for a tension-type
we're out
headache
of time.
is.
In fact, we're over time, so I'm going to have to stop you there. But
Sorry.
Thank you so much for coming in.
You're very welcome.
To you and Helena and Vinod and to Corinne for all you're doing at OPHM. It's a great project. Please get involved. And Justin will put up the details again, the email address on the screen while I'm talking. Thank you, Justin. And get involved. If you're an osteopath, you can do that. Chiropractors, you've got a few months to wait, but get involved in this because this is going to be so important in the credibility of our professions. Anyway, I hope you've enjoyed today's show. I know I have, and I'm sure we'll be hearing more from Liz and the team in years or months to come. But that's it for now.